Thank you very much indeed, Karen, and to the STS for the invitation and that kind introduction. So the remit I was given was mesothelioma. The role of the surgeon is to palliate only. And as you can see, like my colleague Felix, I'm a chest physician, so I'm next up on the sacrificial altar of the thoracic surgeons. I don't have any conflicts of interest to declare, first of all. And what I'm going to do over the next few minutes is go through the outcomes from some of the major surgical trials in mesothelioma to date, and to look at some of the current and proposed surgical trials. And then finally talk briefly about my thoughts on the role of the surgeon in the management of mesothelioma. Now, this could actually be quite a short talk, because actually, with no known cure, all treatment, including surgery, is by definition palliative in mesothelioma currently. But for the purpose of this, we'll be a little bit more thoughtful. And what I'm going to do, as I said, is look through each of the major types of thoracic surgery that have been tried over the last few years in mesothelioma. So, first of all, extra-pleural pneumonectomy, EPP. Now, there's a common pattern which you'll see over the next few slides, and that is this all started off, the EPP story started off with a number of case series, historical case series, which suggested that EPP improved outcomes and survival, quality of life and so on in patients, and these were non-randomized, uncontrolled case series, quite large, some of them. And many of you are aware of the Mars-1 study, which Tom Treasure and co, and some of the people in the room probably were involved in, which was published in Lancet Oncology in 2011. And that was actually a feasibility study. It wasn't a fully powered study, it was a feasibility study. And what it showed was that, in the end, that patients in the non-surgical arm of Mars actually did better than in the surgical arm. So the odds ratio was 2.75. If you had surgery, you were more likely to have a worse outcome. And that the patients in the non-surgical arm actually did better than not only in the surgical arm, but in other contemporary studies of EPP. So this is some data that Tom Treasure published in an editorial he wrote in JTCVS earlier this year, in the last month or so. And he looked at some studies by David Rice and Roger Flores and others. And essentially you can see the patients who had EPP did not fare as well as patients who had no EPP. And as you're probably well aware, the result of this sort of work and the Mars-1 study, which didn't go on to the full randomized controlled trial, although it has been an area of prolonged and vigorous debate both in the written literature and in meetings such as this, both in the UK and abroad, is that looking at this data from your own SCTS, courtesy of Doug West, that if you look at EPP on the top line, which is the green bars, there is virtually none being done in the UK currently. And I think this pattern has spread in many countries around the world as EPP has virtually disappeared. So the next up is the VATS partial pleurectomy. And again, historical, non-randomized studies suggested that VATS pleurectomy was effective for controlling pleural effusion and may be associated with prolonged survival compared with tout pleurodesis. And on the basis of those 2 or 3 small studies, the MESO-VATS study was born, which, as you know, I was pretty heavily involved in, and ended up running for the last 10 years or so of its life. It was a multi-centre study based in the UK, 196 patients randomised to partial pleurectomy versus tout pleurodesis. And the primary endpoint was survival at 1 year. Now, in retrospect, that was probably not the correct primary endpoint, but that was the primary endpoint that was set at the outset of the study. And the secondary endpoints were quality of life, health economics, and complications. And as you're aware, there was no difference in the survival at 1 year in the two groups. So the two survival curves overlapping there. And if we look at the quality of life, the only thing which came out in this study was that there was a suggestion that patients in the surgical arm had an improved quality of life, which started to appear around about 3 months and 6 months and 12 months. It became significant, although, of course, as you have to remember that over the period of these patients surviving, the fittest patients and the ones doing best survived. So the people with the highest quality of life were the ones that kept living, as it were. Or if you were still alive, you reported higher qualities of life, depending which way you want to look at it. So the quality-adjusted life years, however, were very expensive, and it is greater than the £50,000 set by NICE. So it's very unlikely that VATS pleurectomy decortication for mesothelioma will actually be approved. And again, if you look at your SCTS data here, it's quite interesting that the blue bars are the VATS pleurectomy decortication, and you can see how it has fallen off over the last few years. In fact, it seemed to start falling off just around the time we finished recruiting patients to the study. So some of it may have been patients actually being in the study in the first bar, but it certainly dropped off. So again, VATS pleurectomy decortication seems to potentially not be the way forward if patients having talc have as equally good outcomes. So the next thing is pleurectomy decortication, so open pleurectomy decortication. And again, multiple case series out there, and there's some evidence of survival benefit. But to date, none of the studies have actually compared pleurectomy decortication versus no surgery. So some of the earlier studies compared EPP with PD, but there's nothing with PD versus no surgery. And this is where Mars 2 and Eric Lim and his team are trying to address this difficult issue. And again, it's a feasibility study initially. And the primary objective is to determine if it's feasible to recruit into a multimodality trial of pleurectomy decortication in addition to chemotherapy versus chemotherapy alone. And again, it's going to look at harms because it's a feasibility study. It will also look at evidence of harm. And if the feasibility study is successful, it will progress to a full randomized controlled trial. And in fact, the feasibility study is progressing well. They are recruiting very well. And as many of you know, Eric has recently put out a call to open further surgical centres for Mars 2 for the full study. So with regard to PD, the question is still up out there. I'd just like to put in briefly a little plug for a new study called Mesotrap, which we're developing. The trapped lung in mesothelioma is a big problem. It's not that common, but it is a major management problem for patients who are unfortunate enough to have trapped lung. And having seen quite a lot of cases of trapped lung over the years, when you look at the literature, if you read the thoracic surgical literature, a lot of that literature is around VATS pleurectomy decortication. If you read the chest physician literature, they tend to plump for indwelling pleural catheters. So it seemed opportune time to actually look at setting up again a feasibility study of randomizing patients to either VATS pleurectomy decortication versus an IPC. And we've got funding for this from one of the NIHR funding streams. And the primary endpoint will be to randomize 36 patients in 18 months. Secondary endpoints, quality of life and symptom control. And we hope to get this study open later in the year. So, conclusion-wise, as I said at the outset, at the moment, all surgery for mesothelioma is in effect palliative. But I think it's a lot more complicated than that, really. I think that surgery does have a very important role, in the multidisciplinary teams that we work in the care of patients. It is not, we're going to do an operation and take away all the disease and cure the patient. We know that's not possible with this disease. Although there are very small numbers of very highly selected patients who do well. There's always a tail on every survival curve in every disease you could care to think of. But actually, I think really the challenge for all of us is to work out which patients, and we're talking about surgery here, so I'll stick to surgery, to discover which patients are best suited for surgery and which operation is best for each patient. And although I've predominantly addressed my comments towards surgery because that was the remit, of course, as we know, it is obviously more likely going forward to be multimodality therapy. So it's more likely to be a combination of chemotherapy, surgery, possibly radiotherapy. And I think over the next few years, hopefully, things will evolve and we'll begin to answer these questions in more detail. We're some way of the way there, but we've got a way to go. So I quite like this comment, again, from that same editorial by Tom Treasure, just to end with. It is the disease that is the problem and the limitations on what can be achieved with surgery, not the skill or the determination of thoracic surgeons. So I'll close there and just leave you with a picture of a vision, another vision for the future, which is Papworth in a couple of years' time when we move. Thank you very much indeed.